Well, thank you very much, Steve, and it's a pleasure to be here to give this talk to you about hybrid imaging systems. I'll do my best to cover this very large topic in the short time I have. Now, first we need to define the term hybrid imaging, and we have many wonderful imaging modalities available to us in both preclinical and human imaging arenas. And I'll define hybrid imaging to be the integration of two or more modalities with the images being registered in space and time. Before the days of hybrid imaging systems, images from different modalities were registered using automated image registration algorithms that would find the combination of rotations and translations needed to register two image sets. This approach is termed serial hybrid imaging, and it works well in the brain, where we have rigid motion, but it doesn't work particularly well in other parts of the body where we have non-rigid motion occurring due to such things as differences in body pose or respiratory motion. In this example, I've shown actually two images from the same modality, MRI, but the principle is the same when you're registering images from different modalities. Now, integrated hybrid imaging, on the other hand, is the simultaneous or near simultaneous acquisition of two or more modalities with a combined modality scanner. And in this example, I've shown a PET-CT scanner, which has both a CT and a PET scanner in the same gantry. The scans are acquired serially, and provided that the patient remains stationary on the bed, the images will be correctly registered. This overcomes one of the major limitations in serial hybrid imaging, as differences in posture and body deformation between the two scans are practically eliminated. To be useful, a hybrid imaging technique should enable the modalities involved to do things that they could not do alone. For example, to answer clinical questions that could not be answered with the scanners separately, to improve the quantitative accuracy of functional molecular imaging studies, and to do these studies in less time, and to reduce costs. The shining example of a successful synergy between two systems is PET-CT. PET-CT scanners come in many shapes and sizes, and these examples are a little dated now, but the basic elements of all PET-CT scanners are the same. We have a gantry with a CT and a PET, and a patient bed that allows scanning by both modalities without moving the patient relative to the bed. And I'll just mention at this point that I don't have any connections with any manufacturers, so if I omit anyone in this talk, if I don't show their product, I apologize in advance. Any that I include are not displayed for commercial reasons. In PET-CT, the CT is normally performed first, preceded by a scout view, which is used to define the axial extent of the scan for both the PET and CT scans. The CT is quick, lasting only seconds, and it's performed in spiral or helical mode with the bed moving axially during the scan. The bed then immediately moves to the PET scanning position, and the PET scan begins. The benefits of PET-CT relative to standalone PET are twofold. Firstly, provided the patient did not move in the short interval between the scans, we have exquisitely registered CT and PET images, providing anatomy and function registered in space and time. This example I've shown here is a patient with pancreatic cancer imaged with the glucose analog FDG. The PET image at the top left shows the tumour clearly, but this image alone provides very little information about the location of the tumour. Localization of the tumour is made much easier, however, when the PET and CT images shown in the other panels are fused. And the fusion image is comprised of both information from both the CT and PET images, the CT shown in grayscale and the PET shown in shades of yellow through to red. red through to yellow, and you get a very clear perception of the location of the tumour shown in yellow. Let me point to that just here, relative to the surrounding anatomy. So the CT provides a very useful anatomical reference. The second advantage of using CT is that instead of performing a time-consuming transmission scan with rotating rod sources as we used to do in standalone PET, we can use the CT data to obtain the information needed to correct the PET image for attenuation. The CT is much faster and provides a low-noise attenuation image. One problem, however, is that the CT scan is performed with low-energy photons, which are attenuated differently to the high-energy PET annihilation photons. We therefore have to apply a scaling to correct the Hounsfield numbers in the CT image to attenuation values appropriately for 511 keV photons. And this scaling is not a simple scale factor, but it varies with the density of the tissue. Further, since the mass absorption coefficients of soft tissue and bone differ greatly at low energies, try this one, and are much the same at the higher energies of CT imaging, we have to use a two-segment scale as shown on the right. We apply different scalings for soft tissue and bone with a breakpoint at about 0 to 70 Hounsfield units. And also the bone scaling varies depending on the kilovoltage of the CT image. Now, despite the advantages of using CT for attenuation correction, it does bring with it the potential for artifacts due to respiratory motion, and one needs to be alert to this. This potential stems from the fact that the CT is essentially a snapshot acquired at a single instant in time, whereas the PET image is an average acquired throughout many respiratory cycles. There is therefore potential for mismatch between the CT-derived attenuation map and the PET image, which causes errors when the attenuation correction is applied. Here we have a respiratory motion artifact in the CT image at the dome of the liver due to respiratory motion, which, when that image was used for attenuation correction, produced an apparent lesion in the lung. And it's only by looking at the image produced without attenuation correction that one can tell that this is actually an artifact and that all the lesions are really in the liver. There are none in the lung. So this is something to be aware of. Now, the success of human PET-CT led to the development of small animal PET-CT systems such as the two shown here, with similar benefits for preclinical translational research. I'll just say now a few words about SPECT-CT. The aims and benefits of SPECT-CT are very similar to those of PET-CT. One can readily accept that the need for an anatomical reference is even more acute in SPECT than in PET because of the inherently lower spatial resolution of SPECT. There can be no doubt that the value of the value in SPECT-CT, which is shown in these images here. So on the left we have a SPECT-CT study. First, the leftmost image is just the SPECT image. It's not easy to see what this apparent lesion is or where it is situated, but when it's combined with the CT image, one can much more easily see where the site of this bone disease is in relation to the anatomy. And on the right, another SPECT-CT example showing an infected screw after a knee replacement surgery, just showing the very accurate localization achievable with SPECT-CT. And while there are many benefits of using CT with PET and SPECT, there are some potential issues that need to be kept in mind. As we've seen, the use of CT for attenuation correction introduces some potential sources of artifacts. The fact that the acquisition of the two modalities is not simultaneous creates a propensity for motion between scans that can give rise to mismatch in localization. And CT can, of course, deliver significant radiation doses dependent on the chosen scan parameters, and these things need to be borne in mind. There are even systems today that can combine all three modalities, PET, SPECT, and CT. For example, the TRIUMPH 2 and Invian preclinical platforms allow trimodality imaging with any combination of PET, SPECT, and CT. Another preclinical trimodality system on the right here is the Carestream Albera, which is a PET, SPECT, CT system. And there is also one for human imaging from Mediso called the AnyScan, which is a SPECT, CT, and PET scanner. I now come to PETMR, which is a hybrid imaging modality that's attracting a tremendous amount of interest at present. A major problem that early PETMR researchers faced was that conventional PET detector technologies based on photomultiplier tubes would not work in the presence of a strong magnetic field. The first solution that was tried was to use optical fibers to transport the light from the scintillation crystals to the PMTs that were situated some distance away. This worked and allowed the PET detectors to be placed right inside the MR scanner, but the main problem was the loss of light in transit. The second approach that was taken, which Dennis has already mentioned, was to replace the PMTs with solid-state devices called APDs that could operate in a magnetic field. It's interesting to note that these earliest attempts were going on in the preclinical rather than the human imaging arena, and that the goal at the very earliest stages was to place the PET detector array inside the MR scanner. Another alternative would have been to develop a tandem design, as shown on the left here, similar to that of PET-CT, using largely existing hardware and with the two scanners separated by a sufficient distance to avoid interference between them. Such an approach is shown on the left, and such a system has been developed by Philips for human PETMR imaging. The integrated design on the right, while technically difficult to develop, does offer some significant advantages. It does enable simultaneous PET and MRI imaging. It would allow higher throughput, and it would give the best image registration. And researchers at the University of California, Davis, developed a PET system suitable for insertion into the bore of an MRI scanner in the late 90s, early 2000s. It comprises 16 detector modules with LSO scintillators coupled through optical fibers to position-sensitive APD detectors. And here's a picture of this system inside an MRI. It's large enough to accommodate a mouse. And here are some simultaneous in vivo PET and MR images of a mouse with a tumor. The top row of images shows the PET alone. The lower row is the MR alone, and the middle row is the fused image. There is a region of hyperintensity seen on the MRI image in the center of the tumor, which corresponds to an area of reduced FDG uptake in the PET image, which indicates possible area of necrosis. The success of these preclinical systems inspired the development of the first integrated PETMR system for human imaging, the Siemens Brain PET. The PET insert with APD detectors was designed to fit inside the bore of a standard Siemens 3 Tesla MRI system. It also inspired other major manufacturers to develop PETMR solutions, in this case a serial hybrid system from GE with the scanners in separate rooms and a docking mechanism to permit reproducible positioning of the patient bed. and this tandem design from Philips, with both scanners in the same room and sharing a common patient bed, but with the scanners separated to avoid interference. The PET systems in the GE and Philips systems both have time-of-flight capability. And as Dennis showed, the first integrated whole-body PETMR was recently released by Siemens. This has a patient opening of 60 centimetres, and APD-based PET detectors are built into the MRI gantry. Like the earlier brain PET, this system is capable of simultaneous PETMR imaging, in this case whole-body imaging. However, it does not have time-of-flight capability. Here are some clinical images published by Pichler and colleagues from Tübingen in Germany, which compare PET-CT and PET-MRI in a 71-year-old woman with a frontabasal meningioma in the olfactory region. The superior soft tissue contrast is very evident in the MRI images as compared to the CT. The PET tracer used was a gallium-68 tracer Dotatok. A second meningioma was seen on the PET image in the frontal area here, which was may correspond to an area of abnormality seen on the MR image, but not seen on the CT image. This may indicates the potential value of having that additional soft tissue contrast. An exciting possibility with PETMR is to combine the functional capabilities of both modalities rather than using the MR image solely as an anatomical reference. For example, one could correlate fMRI and PET findings, or, as shown here, use MR spectroscopy to interrogate the biochemical composition of tissues in selected regions. With fully integrated systems, this could even be done simultaneously. One drawback with PET-MR is that the MR image does not provide any information about tissue attenuation, which presents a challenge for attenuation correction of the PET data, particularly in the thorax. There's been considerable effort devoted to methods of obtaining accurate attenuation correction factors from the MR scan. One approach is to match a standard MRI atlas and a co-registered CT attenuation map to the patient's MR image using non-rigid image registration techniques. Another method shown here is to attempt to synthesize an attenuation map from separate water and fat images acquired using a two-point Dixon MR protocol. This is subject to some error as it excludes bone, but as shown in this example, when the result of applying this for attenuation correction is very similar to that obtained with conventional CT-based attenuation correction. So to summarize, replacing the CT of PET-CT with MR provides some potential strengths. We have potentially excellent registration of structural and molecular imaging data with better soft tissue contrast. We have anatomic priors that could be used in PET reconstruction or for partial volume correction or for data modeling. PET can be combined with other advanced MRI techniques such as fMRI, diffusion-weighted imaging, MR spectroscopy, and MR molecular imaging agents to do combined functional studies. There is no additional radiation dose from the MR, and there is the potential to obtain motion information from the MR for motion correction of the PET data. Weaknesses are that it's potentially more expensive than PET-CT, and there is attenuation information is not directly measured as it is in CT. And at this early stage, there is still uncertainty regarding throughput, cost effectiveness, and its ultimate clinical role. Now, in the remaining time, I would like to briefly refer to some other hybrid imaging techniques. And I think I have about 10 minutes left, Steve. There are, of course, many imaging modalities and many potential combinations. We've covered a few already, but there are also others shown here in black, and I will attempt to cover the essence of a few of these. There are many hybrid modalities that incorporate optical imaging as one of the modalities. By optical imaging, I mean fluorescence and bioluminescence imaging, both planar and tomographic. Due to its limited depth penetration, optical imaging is used mainly in preclinical imaging. So the imaging technique itself is only translatable to humans to a limited extent, but of course outcomes of preclinical research with optical imaging are translatable to humans. Got some competition. Here is an example of a hybrid optical system from Carestream. The system can deliver optical or radioisotope images registered with a planar X-ray for localization. The examples on the right from the Carestream website show images obtained with near-infrared fluorescent probes co-registered with an X-ray to localize the source of fluorescence. It's not an emergency, is it? I wasn't listening. I hope not. Optical and X-ray imaging can also be done tomographically, of course. And here is a hybrid fluorescence molecular tomography, or FMT, image, FMT computed tomography system built around a GE micro CT system. The fusion image on the right shows a study of a nude mouse with a neck tumor and illustrates that the CT image can be used for localization of the fluorescence emission in a way analogous to PET-CT. Another very interesting technique is photoacoustic imaging. The principle here is that one illuminates living tissue with pulsed laser light. Cells or imaging agents with specially chosen optical absorption properties in the tissue heat up, causing a thermoelastic expansion that emits sound that can be detected with an ultrasonic transducer in a manner similar to conventional ultrasound. A variant of this technique called thermoacoustic imaging uses RF pulses rather than light and can thus penetrate to a greater depth. Differences in the optical absorption of endogenous substances enable studies of, for example, hemoglobin concentration and oxygen saturation. And the technique provides inherent co-registration of the photoacoustic signal to its anatomical source and can be performed in real time. Here's an example of a photoacoustic imaging system from Visual Sonics, which simultaneously acquires co-registered photoacoustic and micro-ultrasound data. On the right, again from their website, is an illustration of real-time imaging of changing oxygen saturation as a ligature on a mouse hind limb is tightened. Optical imaging has also been combined with MRI. This slide illustrates serial fluorescence molecular tomography, or FMT, and MR hybrid imaging in a mouse with an implanted glioma. The fluorescence imaging was performed using a Vizen FMT system. Immediately afterwards, MR imaging was performed in a Bruker 7T MRI. The two studies were then co-registered using automated image registration software. Results here show tumor protease activity on two separate days, 6 days apart, as the tumor developed. Optical imaging has also been combined with PET. And here is an example of a correlation study performed with a nanoparticle multi-modality probe incorporating both a radioactive and fluorescent marker in a mouse with bilateral flank tumors. The PET-CT was performed on a Siemens Invion system, and FMT was done on a Vizen FMT system. The images were then co-registered using fiducial markers, and good correlation of the fluorescence and PET signal was observed. So finally, to the future. It's always hard to predict the future, but I'm sure we'll continue to see further refinement of hybrid imaging technologies and the emergence of new ones. We're also likely to see significant development of multi-modality imaging agents to increase the information that can be obtained from hybrid imaging. And just to support this last point, I'd like to finish with this very nice work from Nature Medicine earlier this year. It describes the triple modality contrast agent called the MRI Photoacoustic Raman, or MPR, nanoparticle. This nanoparticle is comprised of a gold core coated by a Raman active layer with a silica shell containing gadolinium on the outside. So the images on the left column at the right were obtained in a mouse with an implanted glioblastoma with the 3 modalities prior to the injection of MPRs. And then the MPRs were injected, and after injection, the MPR particles diffused through the circulatory system, diffused through the disrupted blood-brain barrier into the tumour. But being too large to cross the blood-brain barrier, the MPRs remained in the tumour and did not accumulate in healthy brain. The images in the right column demonstrate the enhanced signal obtained with all 3 modalities after MPR injection, and you can see that the signal increased in each of the modalities. The upper image, by the way, I should have explained, this is the, sorry, I can't even talk. The MRI is at the top, of course, the photoacoustic in the middle, and the Raman image is in the lower position. So the way that this would be used eventually in clinical use is that the MRI image would enable surgical planning. The photoacoustic image, with its relatively high resolution and deep tissue penetration, would guide bulk tumour resection intraoperatively. And Raman imaging, with its sensitivity and spatial resolution, would be used to remove any residual tumour and for subsequent examination of tissue specimens ex vivo to verify tumour margins. So with that, I will end. Thank you very much.